Welcome to Lexcura Clinical Insights, the podcast where clinical evidence, healthcare standards, and litigation strategy come together. I'm Michelle Carroll, founder and chief clinical strategist of Lexcura Summit. Home health is one of the fastest growing care settings in healthcare, and one of the most legally complex. The CMS conditions of participation establish specific requirements for skilled nursing supervision, home health aid oversight, adherence to the plan of care, and documentation of ordered visit frequency. When a patient is harmed in the home health setting, one of the first questions is whether the agency actually delivered the care that was ordered. In this episode, I will explain how to evaluate home health supervision standards, review visit frequency documentation, compare the plan of care with the services provided, and identify deviations that may support a breach analysis. Okay, so here's something to think about. In home healthcare, the frequency of visits isn't just a scheduling detail, it's actually a form of clinical evidence.
Oh, that's interesting. You're saying the visit pattern itself tells us something about the care being provided?
Exactly. When an agency sets a visit schedule, they're making a clinical judgment about what the patient needs. And when you look at the actual visit log, the record of what happened, you're seeing how that judgment was carried out in practice.
So, if there's a gap between what was planned and what was delivered, that's a red flag?
Absolutely. That gap can reveal whether the agency took the physician's plan of care seriously, or if they deviated from it without a valid clinical reason. And it's not just about the visits themselves, it's also about the supervision structure that supports those visits.
You mean the nursing supervision of home health aides?
Exactly. Home health agencies are required to supervise their aides through a registered nurse or another skilled professional. And that supervision isn't just a formality, it's a critical clinical function.
So, it's not just about making sure the aide is doing their job. It's about ensuring the patient's condition is being monitored and that the care plan is being updated as needed.
Exactly. The supervisory visit is when the nurse assesses the patient, evaluates the aide's performance, and determines whether anything needs to be escalated or changed.
And when those supervisory visits don't happen?
That's when you have what's called a supervision gap. During that gap, the aide essentially becomes the primary clinical presence for the patient.
Which is a problem, because aides aren't trained to make clinical assessments.
Exactly. They can observe changes in the patient's condition, but they don't have the expertise to interpret those changes or determine whether they're significant.
So, if there's no nurse providing oversight, those observations might not lead to any action.
Right. And if the patient's condition deteriorates during that time, the supervision gap becomes a key liability issue.
It's a structural failure, not just an individual error.
Exactly. And that's what makes it so significant in litigation.
Let's talk about the regulatory side of this for a moment. What does CMS actually require when it comes to visit frequency and supervision?
Good question. On visit frequency, the CMS conditions of participation require that agencies provide care at the frequency specified in the physician-approved plan of care.
So, the agency doesn't get to just adjust the frequency based on what's convenient for them?
Correct. The frequency in the plan of care is a physician-ordered requirement. If the agency wants to change it, they need to document a clinical reason and get physician authorization.
And what about supervision?
CMS requires that agencies supervise each home health aide at least every 14 days. And that supervision has to include a clinical assessment of the patient.
So, it's not just a check-the-box kind of thing.
Exactly. It's a critical part of ensuring that the patient's needs are being met and that the aide is performing their task correctly.
And when those requirements aren't met, it creates liability.
Exactly. And it's not just about the individual failures. It's about the system as a whole.
Let's shift gears a bit. You mentioned earlier that visit frequency can also be a liability issue when it doesn't match the patient's clinical needs. Can you explain what you mean by that?
Sure. This is a more subtle issue, but it's an important one. Sometimes the visit frequency in the plan of care is too low to begin with.
So, even if the agency delivers exactly what was ordered, it's still not enough?
Exactly. The argument is that the patient's condition required a higher frequency of visits than what was ordered, and that the harm that occurred was a result of that inadequate frequency.
And to make that argument, you need to show what the patient's clinical picture looked like at the start of care.
Right. You need to look at the OASIS data, the physician's orders, the nursing assessment, everything that reflects the patient's condition.
And then you argue that a competent clinical assessment would have supported a higher visit frequency.
Exactly. And you also need to show that the harm that occurred was something that could have been prevented with more frequent monitoring.
That's a strong argument, but it sounds like it requires a lot of clinical expertise to make effectively.
It does, but when it's done well, it can be a very powerful liability theory.
Let's wrap this up with some takeaways for attorneys.
Sure. First, distinguish between two separate liability theories: missed visits and inadequate visit frequency. Both are viable, but they require different kinds of evidence.
Second, always request supervisory visit records. If they're missing, it's a strong indicator that the supervision obligation wasn't met.
Third, focus on the supervision gap when the aid was the primary clinical presence during a period of patient deterioration.
Fourth, compare the OASIS clinical profile to the visit frequency ordered. If there's a mismatch, it's evidence of inadequate clinical judgment.
And fifth, remember that visit frequency arguments require a causation bridge. You need to connect the breach to the specific harm that occurred.
That's a lot to think about, but it's also important.
It really is. Visit frequency and supervision are more than just operational details. They're critical components of patient care.
And when they're not handled properly, the consequences can be serious.
Exactly. Well, that's all we have time for today.
Thanks for walking us through this. It's been a fascinating discussion.
My pleasure. Until next time. Thank you for listening to LexCura Clinical Insights. In home health litigation, supervision and visit frequency must be evaluated together. The plan of care establishes what services were ordered, while the visit notes, scheduling records, supervisory documentation, aid records, and communication logs show what the agency actually delivered. The key is to determine whether the agency followed the ordered frequency, provided appropriate oversight, responded to missed or delayed visits, and documented changes in the patient's condition. When the record shows a clear difference between the care required and the care provided, that deviation may become the foundation of the breach analysis. The final step is connecting the missed supervision or service gap to the deterioration, injury, or hospitalization that followed. For more clinical intelligence, litigation analysis, and practical guidance, visit LexCura Summit at lexcurasummit.com. I'm Michelle Carroll. Thank you for joining me, and I'll see you in the next episode of LexCura Clinical Insights.